Good afternoon to those in this time zone, good morning to those in the morning time zone, and good day in general. Thank you for joining us for the second day of this two-day webinar, which is focused on the Global Adult Tobacco Survey, GATS-SA, looking at the implementation, the results, and the implications for policy. This webinar is hosted by ISSUP South Africa, that's the International Society of Substance Use Professionals, its South African chapter, with the support of ISSUP Global and in collaboration with the International Technology Transfer Center South Africa at University of Cape Town. So we thank you for taking time to join us today. And for those who joined us yesterday, Dr. Nkosi presented initially about the processes of developing and implementing the GATS-SA. And Dr. Egbe then came across and discussed with us some of the findings that came out of the study. So we look forward to engaging today with the policy implications. And with that, I hand over to Roger to take us through it. Thank you very much.
Thank you, Professor Sebeko, and a very warm welcome to everybody. I'm Roger Wyman, a member of the ISSUP South Africa National Chapter. We want to thank Dr. Egbe and Dr. Nkosi for hosting the second session and the South African Medical Research Council. Just a bit of housekeeping. Please remember, if you do have any questions, please post them in the question box. We will have a question and answer session towards the end of this webinar today, and we will be dealing with some of the questions that were posted in yesterday's session. So to start with, I'm going to introduce both of our speakers. As Professor Sebeko mentioned, Dr. Nkosi and Dr. Egbe both presented yesterday. Dr. Nkosi is a senior scientist at the Alcohol, Tobacco and Other Drug Research Unit of the South African Medical Research Council. She holds a research associate position at Rhodes University. She has a PhD from the University of South Africa, while her work largely focuses on men and masculinities within various cross-cutting fields, including substance use, mental health, violence, and HIV. She serves as a project manager for the GATS South Africa project. Dr. Nkosi will be available to answer questions towards the end of today's session. Our speaker today, talking about the implications for policy related to the GATS survey, is Dr. Catherine Egbe. She's a specialist scientist in the Alcohol, Tobacco and Other Drug Research Unit of the South African Medical Research Council. She obtained a PhD in psychology and health promotion from the University of KwaZulu-Natal. She's an alumni of the prestigious Center for Tobacco Control Research and Education, University of California, San Francisco. She's also a World Health Organization Collaborating Center for the Tobacco Control. Dr. Egbe is a member of the Society for Nicotine and Tobacco Research and was a fall 2016 Global Health Network Spotlight winner. She is currently the lead investigator of South Africa's first Global Adult Tobacco Survey 2021, Tobacco Endgame in Africa, and University Students' Exposure to E-Cigarette and Hookah Marketing Studies. And on top of all of that, she's also authored in excess of 50 academic publications, including 43 papers in peer-reviewed journals. So we're extremely privileged to have two presenters of such esteem presenting their findings of the GATS-SA survey. Over to you, Dr. Egbe.
Thank you very much, Roger. Please confirm if you can see my screen.
Yes.
Okay, thank you very much. Okay, so thank you for having me once again, and I'll just do a very brief recap of some of the things we talked about yesterday, looking at the methodology of the GATS-SA, as well as some of the key results. But very briefly, this survey was conducted between May and September 2021, and we had a total sample size of 6,311 And our sample was comprised of people aged 15 years and above. It was a national household survey, so it happened in all 9 provinces of South Africa, and the response rate was 91.5%. Our key partners are the WHO, both the Afro and South African office, the CDC Foundation, the National Department of Health, on whose behalf we conducted this survey, as well as Statistics South Africa. The key results, the survey actually looked at tobacco and electronic cigarette use, prevalence, as well as smoking cessation, secondhand smoke exposure, economics of tobacco use, media, as well as knowledge, attitudes, and perception. The summary of the prevalence of use showed that about 29% of South Africans are using various forms of tobacco products. About 4.3% were using smokeless tobacco products, while 25.8% were using smoked tobacco products. So this includes the manufactured cigarettes, roll your own cigarettes, hookah, pipe tobacco, and other combustible products. We also talked about the prevalence of use of electronic cigarettes, and I mentioned that we need to understand that this is just 15 years and above, because that's the minimum age for the GATS. And the overall use was 2.2%, but those aged between 15 and 24 were found to be to have the highest prevalence of use, way above the average or the overall use. I also mentioned about the fact that if you plug what we've just talked about the prevalence of tobacco use in South Africa to this table with other African countries, you'd see that South Africa is way above the prevalence of use in the closest countries, Botswana. We are almost double that number, because we are the first country in Africa that is going above 20% and even close to 30%. And this should worry any one of us who is a public health scientist or in substance use corridor of research. So someone was asking about the comparison of prevalence among South Africans going by other studies that were done before the GATS. And I decided to put this slide here. I mentioned about the South African Social Attitude Survey, which is one that I've been using to track the prevalence of use. And you can see from these graphs, if you look at the top graph, you'd see for cigarette that in 2007, it was at 19.3%, sorry. In 2010, it fell to 16.1%. I think that was the lowest. And since 2010, it's been rising. The last SASAs that I have access to is the one conducted in 2018, and the prevalence was 20.4%. And if you look at, this is just manufactured cigarettes. So if you add roll your own cigarette to this cigarettes, you'd see that this would be higher. And then if you add cigar and hookah, this will likely be higher. And for e-cigarette, what we found here in the SASAs is showing that the use of e-cigarette has increased by a whopping more than 500% since 2010 when it was tracked. And you can see that that is something that we should worry about. If you look at the bottom graph, you'd see that looking at the trends of dual use of tobacco and nicotine products, you'd see that in all the products, both the use of cigarettes and smokeless tobacco, cigarettes and hookah, and cigarettes and e-cigarettes, the trends does not look good, because everything is, or the prevalence is increasing. So we cannot talk about policy implications without talking about the South African legislative space about tobacco control. So the very first act, the Tobacco Control Act 1993, It was passed in 1993 and then amended a couple of times. The last amendment was done in 2008 until in 20, so of course, before this 1990, that is after 1993, we know that South Africa signed the Framework Convention on Tobacco Control, which makes it obligatory for South Africa to pass comprehensive laws using the template of the FCTC, so that the laws that we have will cover all the products. The laws that we have will be updated in terms of international best practice, because the WHO FCTC is it comprises of many evidence-based approaches to use to control tobacco. So of course, within this period between 2008, the last amendment, and now, we know that there are many new products that have been introduced into the market. And of course, like I showed you in one of the previous slides, prevalence of use has been increasing. And these new products, some of them are not covered by the old, the current law, the Tobacco Control Act amended 2008. So for example, e-cigarette is not covered by this law. And some would argue that hookah is not covered, but I would say hookah is a tobacco product, so it ought to have been covered. But we know that many of the regulations that have been that were put out there for the Tobacco Control Act were not being obeyed by those marketing hookah. Now, this regulatory gap is costly in all ramifications, because the latest publication looking at the burden of tobacco use in the country shows that about 31,000 South Africans die annually from tobacco-related diseases. And some studies have also been done by our colleagues in RIP UCT, showing that the government spends about 14 billion rand on healthcare for those suffering from tobacco-related diseases. Another big issue about this legislative vacuum is that young people are the targets for both the old and the new products. So even though we have these new products being marketed in very interesting ways, which I will talk more about later, we also know that the old products are still being targeted at young people. We'll talk about the reason why later. Now, in 2018, the Department of Health released a bill that was called the Control of Tobacco Products and Electronic Delivery Systems Bill. And the overall purpose of the bill is to actually phase out the old bill and introduce new regulations or new laws that will cover some of these things that I've just mentioned that are not covered by the old bill. So the 5 key areas of the bill were, the first one would be the 100% smoke-free indoor and certain outdoor places. Yesterday I mentioned that entertainment venues like hotels and restaurants, if they wanted to, they could designate 25% of their floor areas for smokers. But we know that that doesn't work. Even in South Africa, my colleagues have done studies where they've looked at whether the places where people who don't smoke eat are infiltrated by smoke from the designated smoking areas, and they found that yes, indeed, you cannot really close the door against a gas. So the new law seeks to phase out designated smoking areas and make indoor places, as public places, as well as certain outdoor places, to be 100% smoke-free. The second thing about the law is to phase out what we currently have on our packages, which is a textual health warning. The WHO recommends that that countries should actually look towards putting graphic health warnings. not just textual health warnings, because not everybody can read, and there's no one who would see a picture that wouldn't be able to appreciate the picture if the picture shows some of the diseases that could be caused by smoking. So the second aspect of the law is to phase out the nice looking packages of tobacco products, those exciting colors, and have a drab color with graphic health warnings. And then the third one is to regulate e-cigarettes. Like I mentioned yesterday, e-cigarettes are not currently being regulated in South Africa. They were presumed to be regulated by the Medicines Control Act, which regulates nicotine products. But we know that based on that act, no one should be able to buy cigarettes over the counter. It's supposed to be prescribed by a medical professional, but that is not the case. We know that you'd see some pictures that I will show you of e-cigarettes being marketed in very interesting places around the country. So the law would, if passed, would regulate e-cigarettes. The fourth one is to remove point of sale advertisements and marketing, which are known to encourage people to smoke, especially young people. And the last, but definitely not the least, is the removal of cigarette vending machines. The current law allows people to have vending machines in places where you have adults. But we know that most of these places are not usually manned by anyone. That would require you to provide your ID before you buy. The machines do not ask you for ID, so of course people can access it. Recently, I think it was a couple of weeks ago, maybe 2 weeks or thereabouts, this law that was put out for public comments in 2018 was moved to the parliament. So after the public comments, comments were gathered, and the law was updated. I was told that more consultations were held, and the law was updated. The bill, not the law yet. The bill was updated, and it's now called the Tobacco Products and Electronic Delivery Systems Control Bill of 2021. And so the next step for the bill is for it to go through the Parliament Committee on Health, and then we'll have public hearings, and then it will go to the provincial councils, the National Council of Provinces, and then there will be public hearings in the provinces before it moves to the stage where it can be passed. So how does GATS relate to all these things I've been saying? And just to mention that the updated bill still has those 5 provisions I just explained, and they are explicitly stated on page 38 of this document. So I'm going to talk about GATS in relation to each of these 5 components, and then talk about some recommendations at the end. So yesterday I presented this slide where we found that about almost 75% of those who visited bars, taverns, pubs, shebeens, and nightclubs were exposed to secondhand smoke. The reason why this bill is quite timely is the fact that such entertainment venues where designated smoking areas were allowed if the owners wanted it, they would be phased out. I must also mention that many restaurants, I think there was a study done by colleagues in Sefako Makato Health Sciences University, and they found that many restaurants have actually gone smoke-free. Many hotels have actually gone smoke-free. So it wouldn't be a shock to the country, for example, if this provision of the bill comes into play. Of course, the most important reason for this is to protect non-smokers and to protect workers who need to serve patrons in these designated smoking areas but do not smoke. And even if they smoke, taking in more smoke is never a good idea. So it's to protect the workers as well as to protect non-smokers. And of course, yesterday I also mentioned that 88.4% of our participants in the GATS mentioned that they would support a ban on smoking in indoor workplaces, and in certain public places, which means there's good support for this aspect of the bill. The second aspect is plain and standardized packaging for tobacco and nicotine products. So we included a couple of questions to gauge the effect of the current health warning. So if you look on my right, on your right as well, you'd see the tobacco packages as we have them in South Africa currently. So you have smoking damages your lung, tobacco is addictive. That's just the health warning. And then it comes with all these exotic colors. So we asked participants whether they noticed health warnings on cigarette packs, and these were smokers, and about 80% said they noticed it. But interestingly, less than half of them said they thought about quitting because of the health warning. For me, this actually shows that the health warnings are not really working, because if you look on your right, you would see the replica of what we would be having if this law passes. And I don't think that one who sees these two packs will feel the same way about, quitting. One would definitely think more about quitting than the other. But we went on to ask about hookah, if those who use hookah have actually noticed health warnings. Less than half said they noticed health warnings. And even among the less than half who noticed, less than half thought about quitting because of the health warnings. We also asked about smokeless tobacco, and just a little above 50%, about 52% said they noticed health warnings on the smokeless tobacco pack, and less than half of that percentage also said they thought about quitting because of the health warning. But we didn't stop there. We also asked this question, that when smokers want want a cigarette, would the written health warnings stop them from smoking? Of course, a lot of people disagreed. That is, we asked them if the written health warning was not going to stop them from smoking, and 67% said it wasn't going to stop them from smoking, and 33% said, well, it could stop them. And we also asked about, a situation where we had graphic health warnings. So we had our show cards in the GATS. We had a show card with the picture of how a plain package would look like with a graphic health warning, like the one I just showed you on the previous slide. And then we asked people, adding these graphic health warnings on plain packages, will it make smokers think more about giving up smoking? And majority, 58% said yes, it will make them think more. 42% said they disagreed. But it's interesting to know that at least we got the information that this could be an improvement on the current warnings that we have. We also asked about the display of tobacco products in stores, like you have them stacked in very nice corners. We asked if that could encourage young people to take up smoking. So 60% said yes, it could encourage young people, and 40% said they disagreed. I will talk more about the POS, point of sale marketing, later. So on electronic cigarettes, I presented to you this slide showing that the majority of those using e-cigarettes are actually young people. I must also mention that we've done studies looking at the location of e-cigarette shops around South Africa, especially around tertiary institutions, and we found that about 60% of these shops are located very close to the universities and colleges, their campuses. And I'm sure that for those of us who are from the university environment, you would know that when you go around your campus, you would see these hookah shops or e-cigarette lounges and so on. I've seen one around the University of Pretoria, one of their campuses. So I can imagine what that means for these young people, because it shows that they want them to really get on these products. We also did a study with colleagues in the UP and Sefako Makato Sciences University, looking at the influence or the impact of having a vape shop close to you, whether it had an impact on smoking, on using electronic cigarettes. So what we found was that living near a vape shop was associated with a higher likelihood of being a current e-cigarette user. And so these figures that you are seeing, that is particularly higher for those aged 15 to 24, they actually have an impact in terms of increasing use. And unfortunately, this is not the age group that has the highest prevalence of smoking. The highest prevalence of smoking, like I mentioned yesterday, was found around the 45 to 64 years age bracket. But we can see that slightly less than 1% of these people are using electronic cigarettes. Yet, we are told daily that these products are for smokers to quit. I also showed you this slide yesterday, still talking about the fact that e-cigarettes are not, may not be helping people quit as being propagated by the industry. We found that over 20% of those who are using e-cigarettes have been using it for more than 2 years. And that for us is worrisome because it just means that people are getting addicted to these products. We've also done studies to look at even those who claim to use e-cigarettes to quit, whether they used other pharmaceutical products. And we found that those who are using e-cigarettes are more likely to be using other pharmaceutical products to quit. So at what point do we disintegrate the use of the pharmaceutical products from the e-cigarettes and claim that e-cigarettes are actually helping them to quit? And of course, we know that there is no e-cigarette that has been registered as a quit smoking aid in South Africa. We've thrown that challenge to the marketers of these products that if indeed they are very sure that their products are helping people quit, then they should go through SAPRA and get authorization to sell these products as quit smoking aids so that they can be dispensed just like we do with the NRTs, the nicotine replacement therapy. So this is just a slide showing you some of the advertisements that are taking place in South Africa because of the regulatory vacuum that we have about e-cigarettes. So you have billboards being erected, trucks, and even if you look at this picture at your the top left-hand corner, you can see what's in the yellow rectangle there. It says "Try before you buy." And this is something that is supposed to be harmful to health. And so because there's, you cannot see these things being marketed, you cannot see cigarettes being marketed like this because the current law covers that. You cannot advertise tobacco products. And because e-cigarettes are not currently regulated, the manufacturers and marketers of these products are exploiting this regulatory vacuum. And so with the increase in use by young people, who believe that the law or the bill which currently seeks to regulate e-cigarettes is quite timely and it should be regulated. It should be regulated as soon as possible. This is another picture that I got recently from a colleague. And you can see this is an e-cigarette shop in one of the shopping malls. And you can see the display of these products very much like, maybe like a phone store or somewhere that you can even pass for an iPhone store. So you can see that there's a lot of effort being put to entice young people. Notice the exciting colors. And notice also that, these colors are not just coming in, the colors are coming in very many flavors, as many as you can see there. So most of these flavors are known to entice more young people than older people who we know are smoking more. Now, this is another issue that is coming up with e-cigarettes. I'm sure your first impression about this slide is that, oh, this must be a 20 Rand note. But look closely and you'll see Vape Mate, discount voucher. Discount vouchers are not allowed for tobacco products. So you can see that because of this regulatory vacuum, these products are being advertised and so many regulations in terms of what is not allowed for tobacco is being broken if they were to be applied to e-cigarettes. So hopefully we'll see the end of this soon, but the longer we wait, the more dangerous it becomes for young people, because I could imagine the barrage of advertisement and targeting that is taking place among them. So the fourth point is the advertisement of tobacco products and electronic delivery systems at point of sale. You can see a picture of, this is a picture from one of the sales places in South Africa, and you can see how the colors are so exciting and nice. And we found in the GATS that about 30% of people noticed tobacco advertising, promotion, and sponsorship. So we know that tobacco advertising, promotion, and sponsorship has been banned in South Africa. But because point of sale advertising and marketing is not banned, what the industry is doing is to now use these points as points to reach out to people, to entice people to buy their products. So they make, this is one of like the least you would even find it. There are more sophisticated advertisement taking place in these points of sale. With the current bill, if passed, you would see a plain cupboard with no advertisement, just a plain paper with the price list, as it is done in the United Kingdom and in many other countries. The manufacturers and sellers will not be allowed to do this type of advertisement. So this is a picture from one of the pharmacists in South Africa, one of the pharmacies in South Africa. I don't want to mention names, but imagine seeing this in a pharmacy, and this is a nicotine product. This is an e-cigarette product, looking like, you know, perfume or something very enticing. And so these are the things that would be banned if the law, the bill is passed. Tobacco advertising and promotion from the GATS, we also found that those aged between 15 and 24 years were also the higher recipients of tobacco advertising and promotion. And they were also the ones who noticed any in-store advertising or promotion of tobacco products the most. The last point on the law is the removal of vending machines. What we found in the GATS was that about 1.1% of smokers said they purchased their cigarettes from vending machines within the last 30 days of the survey. This is how the vending machines look like. And of course, you know that there's nobody who is going to be standing there permanently to make sure that people don't buy cigarettes. That those who are underage don't buy cigarettes. So when the bill is passed, if it is passed as it is, this scenario will be phased out. And we can see that we hear a lot of pushback from the industry saying that this shouldn't be, but if just 1% of smokers are the ones using it, so why shouldn't it be phased out? Because if young people are attracted to this in terms of the advertisement, and then no age check, then I think that this is something that we can do away with in the country. So some recommendations from my side would be that, and this is, I'm also going to be talking about some of the results that we found in the GATS. The first one for me is that there is need for support for smoking cessation using evidence-based approaches, so that the tobacco and nicotine industry does not try to make people switch addictions instead of quitting completely. So we know that about 2/3 of the smokers were planning to or thinking about quitting. So we believe that these people need to be offered smoking cessation that is evidence-based. And we know that the majority of these people the people who quit based on the GATS results did not use any intervention, but we also know that some people actually need interventions. And just to mention that there is evidence to show that when you combine therapies, when you combine, for example, pharmacotherapy and counseling, the results are usually better than using either pharmacotherapy or counseling alone. And so we would recommend that such services be made available to people even at primary health care centers, so that more people can be encouraged to quit. The second recommendation is that young people need to be protected from being targeted and recruited to be smokers. What we found in the GATS was that 74% of those who are currently smoking in South Africa started smoking as teenagers. So they started smoking by the time they were 19 years. And the average age of smoking initiation in South Africa was found to be 17.6 years. And we know that many of these minors are not really aware of the harms of these products. Many of them, even when they hear about it, they just know about it like nominally, like, okay, it's harmful to your health. They don't really know the depth of it. And so we believe that if these marketing and advertisement of these products, including using the packs, using the point of sale, are continuously targeted at young people, then we are only going to be seeing a new generation of nicotine addicts being recruited. Another thing we found in the GATS was that about 77% of those who purchased their cigarettes who were aged between 15 to 24 years said they bought from spaza shops. And we know that it's very unlikely that in the spaza shops, people are asked to produce their IDs before they buy anything. So we think that there's a need for more information to be targeted at those who operate spaza shops about the harms of these products and about the need to prevent underage people from purchasing these products. The targeting of young people continues. These are pictures taken from Johannesburg. You can see like very nice colors of shops selling hookah, selling e-cigarettes, and while we wait for the bill to be passed, the targeting continues, and it's not good at all for our young people. So I just want to say that to end that there is need for an urgent passing of the bill, because the more time we wait, the more young people get addicted, the more they are targeted, and we hope that hopefully when we do the GYTS, we'll get a better picture of what is happening with the among the young people. But before then, I think that it's very important that the bill is passed urgently, so that our people can be protected. Thank you very much.
Thank you so much, Dr. Egbe. That was fascinating. I was actually so engrossed in your presentation and just thinking about what is happening just in my part of South Africa. And it is so true about if we look at the psychology of the colors and the marketing techniques that are being used. So thank you so much for that very, very interesting presentation. We do have several questions that have been posed, and I'm going to invite Dr. Nkosi to put her camera on as well. And please feel free to, whoever would like to respond, please feel free to do so. The first question comes from yesterday, and it was posed, why are more women using smokeless tobacco while more men are using smoked tobacco in South Africa?
That's an interesting question, I must say. I think it's culture specific to some extent. Based on research that I've done in Nigeria, what I found there was that it was more discreet for women to use smokeless tobacco products because there's a very high level of stigma for using smoked tobacco products. So women tend to use it discreetly. I don't know if it's the case in South Africa. I actually have a PhD student who is doing some work on smokeless tobacco use in South Africa. Maybe this is one question that would be answered by her, but I believe that it's also part of the culture as well. But I can't say for sure the exact scenario in South Africa.
I completely agree. I think stigma has got a lot to do with it as well, in terms of how people perceive women smoking tobacco and that kind of thing. So I think it is quite a bit of that, but the culture also. Dr. Nkosi, anything you wanted to add to that question?
Yeah, just to say that, I mean, I suppose the marketing also makes a difference. Like your combustible tobacco is generally marketed to men, and there's been studies where they've shown that, you know, there's been marketing like the Marlboro Man and so on. So that appeals to men more than it would to women because of the use of the masculinity and attaching smoking to masculinity.
Absolutely, and as you were thinking about that, I was going back to my youth when cigarettes were allowed to be advertised, and you're completely correct. I mean, if you think about the old Camel adverts, and they were very masculine, very butch in terms of what they were portraying and how, and what market they were focusing on. So thank you for that. Very interesting area of study, perhaps, if we.
Yeah.
If that question. Another question that was posed yesterday, not so much a question, but more of a statement. There was correction on the legal position. Entertainment areas are not supposed to have a smoking area, as Catherine said. They may have, if permitted, but not obligatory. How we use words is important, but I think you have touched on that already today, Dr. Egbe. You did mention that it was in the bill. They are permitted to have an area of up to 25% if they so choose.
Yeah, indeed, yes. And I also mentioned earlier that a lot of these entertainment venues have actually phased it out themselves. Yeah.
Absolutely, and I think I definitely think that is where we are heading in terms of public areas are going to become more and more smoke free. So I think that is progress.
Yes, indeed.
Yeah. All right, so we've got some very interesting questions from today's presentation, so thank you for that. The first one I'm going to pose is from George Marumi, and he says, are there studies to show if the graphics are deterrent for non-smokers?
I think there are studies in other countries that have implemented it. Of course, South Africa hasn't implemented, so we wouldn't have. We only have perceptions. There's studies, behavioral intentions. Would you smoke if you see this, like some of the things I've mentioned? But in other countries where they've been put in place, I think in countries like Australia, I think, was the first to have put the graphic health warnings. There are indeed indications that they are deterrents.
Absolutely, I think that would be interesting to actually look at those studies and see what their results were and what were the outcomes there. Thank you. There's another general question about recommended prevention strategies, and you know, I think this is a very broad question in terms of prevention strategies for tobacco, but maybe we can pose it and sort of throw a couple of ideas out there. The question really is general question about recommended prevention strategies.
So I mentioned about the WHO Framework Convention on Tobacco Control, and I mentioned that it's based on an evidence-based approach to reduce tobacco use. It looks at demand and supply reduction. So not just looking at how to help people to stop smoking, but to actually prevent it. So there are so many articles. We have some of these things I mentioned about the areas that this new bill is, when passed, is seeking to put in place. There are actually provisions made in the WHO FCTC, which have been known, which are known to help to reduce tobacco use. And I also must mention that apart from even the use itself, the WHO FCTC even looks at tobacco farming. It looks at taxation, for example. We know that taxation is one of the most effective ways because many of the people who smoke are actually those in the lower socioeconomic status. So when you increase, and of course, younger people who get to start smoking at a young age, of course, most adults start smoking. In fact, 80% of adults start smoking when they were teenagers. So by that time, they are usually price sensitive. So when the price is increased, the likelihood that they would be experimenting is very, very low. There are some countries that have pushed it further to include what is now called Tobacco 21, where the age limit for purchasing tobacco has now been increased to 21 years instead of 18, as we're having it in South Africa. So there are these provisions in the WHO FCTC, which looks at helping smokers who are currently smoking to stop smoking, which is smoking cessation, smoke-free places. Smoke-free places have also been known to be effective in reducing prevalence, increasing taxes, putting in place provisions to make sure that the manufacturers do not exceed certain limits in nicotine and tar emissions, and so many other provisions. And of course, graphic health warnings. Graphic health warnings is one that the WHO actually recommends a textual health warning that is about 50% or 75% or so. But what we have now in South Africa is not even up to what the WHO recommends. So, and then the WHO also recommends that countries should actually go further to put graphic health warnings. These graphic health warnings are not just pictures of people, but pictures of tobacco-related diseases, the outcome of smoking, which are supposed to deter people from, smoking and deter young people from initiating use. So all these measures, when put in place together, will definitely reduce tobacco use.
Thank you, Dr. Nkosi. Anything you wanted to add?
Yeah, so just to say that, I mean, I suppose what the state can do in terms of reducing demand. But I know that there's also studies that are looking at like the individual level of tobacco use and that issues of like what drives the individual to want the product. So issues of mental health come into play. So there are studies that are ongoing around that, and I'm sure Catherine can speak more to that. But indeed, we need to look at the state level, but also like at individuals and what is driving individuals towards these products.
And I think that that's a very important point that you make, that it's not necessarily only about what the state can do. It's also about what individual, what community, what society itself can also do in terms of playing a role in prevention. And I'm glad that you mentioned that what drives people to start, because that ties in very nicely with another question that was asked. What are the drivers to start smoking? And again, it's a very, very broad area. I mean, if we really have to narrow down the response here.
Yeah. I think that I remember doing my PhD was on looking at these drivers at different levels, starting from the intrapersonal, that is, the individual, your self-efficacy, and so many other factors, as well as your interpersonal, which includes your immediate environment, family, friends, school, and then looking at the society, looking at the laws, what I described as the geopolitical and the social-cultural factors that influence people to use. So at the point where the individual has to come in is when you have to strengthen their self-efficacy. To say no, for example, when their friends offer them. You know that I was talking to a group of young people in South Africa recently, and they were describing how in one school they had a booth where people go to smoke. Like young children go there to smoke, and then the teachers are not aware. They go there, they do their thing. So the way it is, the peer pressure to want to belong, you know, other than the individual mental health and other things that may, because that is also something that is controversial in tobacco control, because we do not really know for sure if it's mental health that pushes you to smoke, or you smoke and then you have mental health issues because of smoking, the addiction and all this stuff. So a lot of things that we need to do is to actually speak to the young people to understand the impact of using these products, and the fact that yes, it may be cool at the beginning, but then when the addiction takes over, you're no longer in control.
Dr. Nkosi, anything to add?
Well, I suppose just to say that, I mean, it's so cross-cutting across the many levels influence each other. So I'm thinking about issues of social norms and what creates the social norms. If there's no if the law around smoking and where you can smoke is kind of lax, and people feel like they can do it anyway, it creates a particular norm of social, like, you know, smoking is quite acceptable, and so all that builds into it. So yeah, it's important, I think, for us to look at what Catherine's example of her PhD, of how she's looked at the various levels of society, the interpersonal, all the way up to law. It's quite important to intervene at all levels.
Absolutely, and it's something that you mentioned earlier on, Dr. Egber, and that is evidence-based, and how important it is that we have evidence-based programs and prevention that we are implementing, and we're seeing this around the world, that there's really this drive towards prevention as a science rather than prevention as a once-off, and if we are going to make a change in the way our country interacts with substances, we have to look at the way we engage with our prevention work in this country, and it needs to be across all levels, as you say.
Yeah, I agree with you. Yeah, I agree with you, because I think it's very important that we look at how you know, evidence-based approaches are pushed out there, because what we're seeing with the industry is that they want to replicate what we would call evidence-based, even when they don't have the evidence. So, and that can lead to confusion, especially for impressionable people, like young people, you know, that easily get swayed when they see a celebrity smoking. They're like, okay, this is cool. But then they hear, oh, it's smoking cessation. I give you an example. When e-cigarettes were being brought into South Africa for the very first time, the Department of Health seized the products, and then the manufacturers or the importers took the government to court. And in their court papers, which I have a copy of, they said these products are not going to be marketed as smoking cessation aids. They are not for smoking cessation. They do not intend to market them as smoking cessation. And then fast forward to 2021, 2018 to 2021, the same people are saying these products are for cessation aids. So if the young people are not aware of, you know, these nuances, they could be carried away by, you know, these narratives by the industry that, oh, these products are good for this. If they are good for this, the public health community is saying, go through the process of getting this product accredited as a medication for cessation. That is not too much to ask, I guess.
Absolutely, no, I completely agree, and that, I mean, that brings us to another question. A question was posed: is electrical cigarettes, are they more harmful for health rather than other types of cigarettes?
So that question, I get that question a lot. So I think that question is not a question that can be answered in one go, because I always say, what we know today about cigarettes, it took us about 100 years to know. There was a time that medical doctors were used to advertise cigarettes as cool things. If you go into, I think it's Stanford that is keeping some of those old advertisements, you would see where nurses and doctors were being used to advertise cigarettes. as something that could help you to relieve stress, to good for you, and so on. But today, what we know is, because of the work that has been done over the years, e-cigarettes are new products. We don't know everything about them yet. But even what we know, we're already seeing them being linked to cancer. We're already seeing them being linked to cardiovascular diseases. We're already seeing unique problems that we didn't see with cigarettes. For example, e-cigarettes exploding. We heard of EVALI, the e-cigarettes and vapor products lung injury disease, which was associated with using vapes for both THC, that's the cannabis thing, and nicotine. A couple of them were found to have used nicotine. Most of them were found to use THC. So there are so many problems. And of course, depending on the type of product used, the products are so varied compared to cigarettes that you cannot even say, okay, this is good for you, because you don't know how that person is going to use it. You don't know how much that person is going to use it. A lot of these things have to be put into consideration in deciding or making a decision about, okay, these products could be safe for you. As it is marketed today to young people, who some of whom wouldn't have even smoked, we wouldn't want to say that that product is harmless. First of all, nicotine itself is not a harmless medication. It's not a harmless drug. It's one of the most addictive drugs. It impacts on the growth of adolescents' brains. So we wouldn't recommend that as a harmless product.
I think that ties in very nicely with the next question, because there's a question from Tebogo from the Department of Health, and they ask, given the health risks associated with tobacco and e-cigarettes, what are the other reasons the products cannot be banned besides the huge tax revenues received from these products? And I think we've touched on that in the previous response already. I think one of the things that you mentioned is that there's just not enough known about these products as yet.
Yeah. So of course, I think she's even asking about both e-cigarettes and tobacco products, why they can't be banned. I think I've heard. I think when I was doing my research, I think one of the smokers are like, why can't these products be banned altogether? So of course we know that there's a big industry behind the products. So even with the laws to regulate them, the pushback, we all were witnesses to the tobacco lockdown ban, just a temporary ban. And the nation was almost set on fire because of that. So I think that some countries have actually banned e-cigarettes, by the way. I cannot say whether that has been effective, but I think over 80 countries have actually banned e-cigarettes altogether. So I think it all depends on what South Africa wants to do, what the Department of Health wants to do. Because at the end of the day, it's all about the people's lives, and it depends on how they want to protect it. If they feel that banning it will not solve the problem, because there will be a lot of illicit products and people using the products illegally, then if that is going to be more of a problem of making sure that people don't use it, if that's going to be more of a burden on the system, I don't think the country will want to go that route. So I guess it's also about can you actually make sure that it's completely banned, given the rate at which we have them around.
Dr. Nkosi, anything you want to add?
No, thanks. I think that was well captured by Dr. Ekpe.
I think, and absolutely, I think if the hard lockdown has taught us anything, the tobacco ban. I mean, if you look at the statistics that you showed earlier on, there was still an increase in tobacco use in South Africa, even during the lockdown. So I think that really has a part to play in the how we are going to deal with the problem of tobacco use in South Africa. And you know what, the one thing while you were talking, I kept thinking about alcohol use in South Africa. And if you look at the permissive nature of South Africans and how we interact with alcohol itself and how we rely on alcohol, and the psychology behind that is definitely something that I feel has a part to play in tobacco use as well. It's still perceived as a permissive drug. You know, it's easy to do, easy to use.
I agree with you. But I wouldn't say for sure, because I think I'd rather focus in the GATS among on those who quit within the past 12 months, because the past 12 months before GATS was actually the lockdown period. So if we have about 11% quitting during that period, that's a good number for public health, I would say. And we cannot really say
Absolutely.
what the numbers were before the GATS, because there was no GATS before then. Like I mentioned yesterday, we have to compare apples with apples so that we can, hopefully when we do another GATS, we'll be able to make such comparison. But for now, all we can say is that some people were motivated to stop smoking, which was good. I got some people writing in and saying, oh, this was helpful for me. Some others smoked more. In some publications I've seen in some countries during the COVID-19, because of the stress of the disease and all the associated issues that came with COVID-19, it pushed some people to smoke more, while some people quit because of it. So it all depends on you know, the individual at the end of the day. Yeah.
Absolutely, and we go back to those interpersonal and intrapersonal reasons that you spoke about earlier on, and that, you know, it's not a one size fits all kind of thing. It's everybody has their own reason for starting and own reason for using. I'm going to move on to another question, and it's from Emmanuel Abraham, and he wants to say, thank you so much, Dr. Egber, for a very enlightening presentation. He says, my concern is the increased prevalence of tobacco use in South Africa compared to other sub-Saharan African countries. Are there studies to show what the country is losing with regards to tobacco-related diseases vis-a-vis what revenue being generated from tobacco products? Also, what is being done to bring the health authorities and the fiscal authorities to a round table so health is prioritized above monetary benefits? I think we're veering into the political field now.
Yeah, it's a long one, but so like I mentioned earlier, there's been a study that was done by colleagues in UCT looking at the cost to the health sector and the cost to government actually for treating tobacco-related diseases in South Africa. And what they found was that over 14 billion was being used to treat tobacco-related diseases, while the industry only brings in about 12 billion in a year. So at the end of the day, by the time you do the subtraction, you'd see that tobacco is costing us more than we are getting from it. So that is the South African scenario. Why it is higher than other countries, I really do not know, but I know that it was worse before the 1993 law, actually. South Africa had as high as 38% at some point in the 90s. And so with the 1993 law, the amendments, that number was beat down. And of course, our law, as at that time in the 90s, South Africa was actually a leader, a regional leader in tobacco control, because the law was quite strong compared to other countries in Africa. And unfortunately, we didn't catch up with the changing times, and some of the products that came lately where they slipped through the regulations, we couldn't be covered, and we have a vicious industry, to say the least, which is not letting down at all in terms of the marketing of their products and introduction of new products. We now have nicotine pouches, which we didn't really, it wasn't really popular when we were doing the GATS in 2021, so we didn't even look at it. But now there's nicotine pouch. So the products are coming in their numbers, And so I think that what the government can do, and what the government has done now with the new bill, is to actually expand the regulatory framework to include related products, so that if tomorrow these companies bring new products, they could be covered. I think that for me is an improvement in terms of the commitment of the government to make sure that the laws are not obsolete so quickly because of the new products that are being introduced. So I think that with the way the new bill is being processed, I am thinking that it's showing some commitment. I'm only hoping that it continues and it's passed soon, because it's been long in coming, because it's like 10 years now. I heard that the SEAS, that's the Socioeconomic Impact Assessment, was done like a couple of years before 2018, which means if we want to count from when the SEAS was done, the law is like so delayed. So we hope that it will just continue being pushed, and because, like I mentioned in my presentation, every delay is costly.
Absolutely, absolutely. We got to try and keep up with the suppliers in terms of what they are flooding the market with, and so it's just unfortunate that from our side, the prevention side and the all of those legislation side takes a lot longer than it takes for them to develop their new products. So
yeah, you're so right.
I've got two final questions, and I think I'm going to ask Odimalam that question first. It says nicotine seems to be more addictive than THC. Can't the amount of nicotine on the cigarette be reduced or mixed with a less addictive substance? Quite an interesting question.
I think it's very possible. I read recently that the FDA is actually looking into regulating the amount of nicotine in cigarettes to make them non-addictive, because there is actually a threshold, as I was told, that the nicotine can be at, and it will not be addictive, because it's the nicotine that makes people want to go back to the product. It's not like they're enjoying it so much, apart from the flavor that is used to make them not to feel the effect of the smoking and all this stuff. So it's very possible. The US, I know, is thinking about that. South Africa, we are only trying to make sure that we get our laws in place to make sure it covers all the products. I'm sure we'll get there someday. Yeah, it's very possible.
But I think something that we need to add onto that question is that you can go to the next level and say, even if we do lower the amount of nicotine in a cigarette, does it make the cigarette less harmful?
I don't think nicotine is not the only substance. Tobacco, so cigarettes has about 7,000 chemicals when it's burnt. 7,000 chemicals. About 250 of them are known to be harmful. About 69 of them are known to cause cancer. So nicotine is just one of so many chemicals. It doesn't make it less harmful. It only makes it less addictive, so that you can. So remember, I said young people start smoking when they really don't appreciate the fact that this product, when you start it, it's going to be difficult for you to stop. If you ask any young person smoking now, he will tell you, "Oh, I will stop when I want to stop." But then he doesn't know that when he wants to stop, it becomes difficult, because it's an addiction. Becomes an addiction. So when you can remove that addiction, then people can make conscious effort. People can make choices. It's only when there's no addiction that you can say somebody is making a choice to smoke. So when you remove the addiction, then the likelihood that the person will return to the product when the person knows it's harmful will be lowered.
Thank you for adding that in, and I think it's important to talk about that. It's I think a lot of people focus only on the fact that cigarette smoke or tobacco smoke is harmful to health, and that's the reason why we are focused on the prevention of it, but actually it's not only about that. It's that is a part of it, but it's also addiction side that we also need to focus on.
Yeah.
And then our final question comes from Tebogo Tladi, and the question is, do we have treatment centers in our country that have treatment programs for cigarette smokers intending to quit?
So that's a tough question. So, but the only treatment center I know is run by Professor Richard Van Zyl Smith of UCT. I heard that some rehabilitation centers, because our unit, the Alcohol, Tobacco, and Other Drug Research Unit, runs the Sekendu program, where we collect data from rehabilitation centers, treatment centers for drug use. I heard that some of the rehabilitation centers are thinking of doing that, but I'm not 100% sure if they have started. But I know that Professor Richard Van Zyl Smith is the only one I know that has a smoking cessation clinic. We also, just to add to this, Roger, one second. Just to add to this, Roger, we also have the National Council Against Smoking, which runs a quit line. They have a WhatsApp line, and then they also have a quit line. And so they have counselors who you can talk to that can help you. Then the Cancer Association of South Africa has an electronic or an online quit smoking program that is called Kickbutt SA. So you can also check that out if you want to recommend it to anyone. Yeah, I think that the numbers for the quit line for South Africa, it's 011-720-3145, and the WhatsApp line is 063-828-2909. So those are what we have for now. And of course, NRTs are available in our pharmacies.
Thank you. Dr. Nkosi?
Oh yeah, no, I just wanted to add that there are those quit lines as well for people who'd like to access help to quit smoking.
Thank you, and I think it's important to if there are people that are wanting to stop and will feel that they need the assistance, that there is assistance out there in terms of outpatient programs that are run by different centers. There are these helplines. There is pharmacological assistance, medical assistance, that kind of thing. But I wanted to just to go back to what Dr. Egber said in her presentation, and how the studies are showing that a holistic treatment, rather than focusing only on pharmacological or therapy, has shown to be a bit more effective. So I think it's important to understand that there is an interplay between all sides of the treatment spectrum, and this is something that we really need to focus on in South Africa. It's not just about the one way is the right way, and I'm going to do it this way, but it really is about what is best for the individual that is coming forward and seeking that help. Right. So any closing comments, Dr. Egber?
For me, I would say that thank you for giving us this platform, and I really hope that as many as joined us would have gained from our experience with the GATS, and at least see what we're doing to make sure that South Africa returns back to the glorious days of having very low smoking prevalence. We hope that we will continue to advocate for smoking cessation to be available at public health centers, primary health care centers, because I believe that when this is taken to the grassroots, people who are interested will be very willing to try to quit. Quitting is beneficial right from the very moment you decide. Within 10 to 20 minutes, the heartbeat is restored. But it will take up to 15 years for the body to recover fully from it. So the earlier a smoker tries to quit or decides to quit, the better. Some people try for more than once. So if you have tried for more than once, please keep trying. It's an addiction. It's not your fault. We are never against the smoker. We are against smoking. So it's very important that you know that you're dealing with an addiction. And with an addiction, it has to do with so many other things, including even the behavioral patterns that you've associated with the use of the substance. So it's very important that you seek help. And when you seek help, please don't give up. That's what I would end with.
Thank you. Thank you so much, Dr. Egbert. Dr. Nkosi, anything from you?
Well, just a big thank you to you, Roger, and Prof. Sibeko and the audience here for having us. I think Dr. Egbe has summarized so well what we'd like to see happen going forward. But I'm just really happy that we've presented this work on tobacco, and that we, it's a space, this platform is for people who are interested in substance use work. And we are recognizing by doing this, by being here, that tobacco use and addiction is also an important addiction to be talking about, because often it's just left on the sidelines and kind of like, it's one of those things. But now here we've brought it here, and people can think about what's out there, what we need to be doing and pushing for in terms of law and treatment. Yeah, thank you.
Thank you. Thank you so much. I completely agree. I just want to, as ISSUP South Africa, I really, really want to thank both Dr. Catherine Egber and Dr. Sebenzile Nkosi for presenting these two webinars for us and providing us insight into the valuable work that you are doing in South Africa. And we look forward to the responses that we've had from this webinar series has been very, very positive. So thank you once again. And we look forward to the next GATS survey, which hopefully in the next 3 to 5 years might be a reality, and we will be able to establish what the work on the ground, if there has been any progress in terms of lowering that 20% to going under 20%. That would be ideal. So thank you once again, both of you. We really do appreciate your time and effort. I am going to ask, I'm going to call on Prof. Sibeko now just to do his closing, and I want to thank all the audience for joining us today. Thank you so much. We really do appreciate it. And please, once again, if you haven't joined our ISSUP network, please remember to join our ISSUP network so that you can be kept abreast of upcoming events such as this one. We have some exciting webinars planned for next year, so keep your eyes posted. Thank you so much, Prof. Sibeko.
Thank you, Roger, and thank you so much to Catherine and Sebe for a fantastic presentation. It's always great to learn from you, and each time I hear you speak, I learn something new. Really thank you to the audience as well for the lively engagement. Not all of it has been shared publicly, but really grateful for that engagement. Please do visit the ISSUP website. You'll see that there's not only a link to other members of the network, but also other teaching and training resources which might be of interest to you. And also keep an eye out for our future webinars. Otherwise, thank you so much for your time, and do take care.
Thank you.
Bye. Thank you. Bye.